Hello everyone, Dr. Matt Ed. Today we'll talk about lipoprotein A. We'll talk about what is lipoprotein A, the pathophysiology, when to test, and its clinical significance. Lipoprotein A, or Lp(a), is a variant of LDL, also known as the bad cholesterol. It consists of apolipoprotein A that is bound to apolipoprotein B100. It is an independent risk factor for atherosclerosis, coronary artery disease, stroke, thrombosis, and aortic stenosis. Patients with a Lp(a) of greater than 50 mg per dl have an increased risk of cardiovascular disease. It could be a possible explanation for younger patients who are diagnosed with coronary artery disease. Currently, there are no FDA-approved medications for the treatment of elevated lipoprotein A. However, PCSK9 inhibitors and niacin can directly lower Lp(a) levels. The pathophysiology is that Lp(a) promotes atherosclerosis and thrombosis. The apolipoprotein has similar structure to TPA, therefore it competes with the plasminogen for its binding site, results in interfering with its function, and causes reduced fibrinolysis. It carries cholesterol, and it attaches to macrophages, forming foam cells, as a result forming atherosclerotic plaques. With regards to testing, it is just a blood test, and the general purpose of screening for Lp(a) is to further identify those at higher risk for cardiovascular disease. The National Lipid Association states to consider testing when there is a significant family history of premature ASCVD in first-degree relatives, personal history of premature ASCVD, and severe primary hyperlipidemia. It also helps to aid in the process of shared decision-making for statin therapy for those in the borderline ASCVD risk. Here are some values. Ideally, should be less than 14. Highest risk is at greater than 50. Borderline risk at 14 to 30. And high risk is 31 to 50. Lp(a) levels directly contribute to serum LDL levels due to its particles containing an LDL particle. So it is part of the calculation in a LDL level. With regard to therapy, niacin can lower Lp(a) by 20 to 30%, but there is no improved cardiac outcomes. Statins can increase Lp(a), but there's an overall beneficial to lowered LDL. And PCSK9 inhibitors lowers Lp(a) by about 26% with improved cardiac outcomes. However, this is a very expensive drug. Its clinical significance helps to identify patients at high risk for CAD in the absence of risk factors, identify patients who need more intensive lipid therapy, and lastly, it is still unclear if direct treatment of Lp(a) can help change patient outcomes from a cardiac standpoint. This is my reference. Thank you for listening. If you thought this video was helpful, please like, subscribe, and look out for my next video.